Okay, today I am delighted to be joined by my former colleague, Clare Fraser, who is a neuro-ophthalmologist in Sydney. And she's going to tell us all about a really exciting test, which I'm very keen to popularize because I'm so impressed with it. So thank you, Claire, for joining us today.
Thank you for having me all the way from Australia. It's nice to see you again.
So Claire, just tell us what you do, just so we get an idea of your job role right now.
So I'm a neuro-ophthalmologist. I work at Sydney Eye Hospital, and my other public hospital role here is at Liverpool. And I do visual electrophysiology through the University of Sydney, where I hold the title of Professor of Neuro-Ophthalmology, and I'm in private practice. So I do a bit of everything, really. It's a nice balance. So yeah, it's good.
So here to talk about this little blue book. Do you want to just show us what that is, first of all? Okay.
Yes,
So why
my
did
very beaten up copy.
well, I mean, it's well thumbed and well used, which is what we like to see. So first of all, just tell us what it is, what it's called, and just summarize, how you got to producing this.
So this is the Queen Square screening test for visual deficits. I found that in the clinic on my fellowship, we were often like trying to desperately find, the Boston cookie thief on a piece of paper and it was all munched up, or you were trying to draw dots or do things in the clinic for testing higher visual processing. And there wasn't one really nice way to do the screening for that. And you might remember that Queen Square got the little green book, which has some of the sort of tests for cognitive function, but doesn't cover visual function. So when I was on my fellowship in Emory, I made up a little one of these for the team. And when I came back to London, I was really keen to do something similar. And with Dr. Gordon Plant, he put me in touch with Elizabeth Warrington and Merla James Galton, who are responsible for some of the bigger visual processing tests like Corvist and VOSP. And so with some of their leftovers, we came to the agreement that we would produce this as just like a little quick screening tool that you could use in the clinic without, having to dig up some old bits of paper. And they're all based on tests that have been properly assessed and researched by Dr. Warrington and Dr. James Galton. It was really great that they were able to let us sort of take the leftovers and put it in here. This was made in copyright 2012, and it's been for sale through the Institute of Neurology in Queen Square for, I think, £10.
It is ridiculously cheap for anything nowadays, and especially essentially a clinic tool. I mean, how is it so cheap?
Um, well, I think there was no copyrights to be paid. None of the three of us who got our names on the back get any money from
So
this,
you're not
and
making
it's
this is not
through
your retirement fund then?
not my retirement fund.
Dear.
Sorry. So yeah, thanks to the Institute of Neurology for publishing this along with their little green book.
Yeah, well done to you and the professors you talked about and the Institute of Neurology for making this so accessible. Right, so what are we going to call it? Because the name doesn't trip off the tongue. What do you call it?
The blue book.
The Blue Book. Let's call it the Blue. Okay, I
Yeah,
call it Claire Fraser's Blue Book, but okay, we'll call it the.
I like that.
Okay, right. So first of all, tell us what are the types of patients where we might want to reach for the Blue Book.
So these are the patients who are complaining about visual difficulty, but there's not much to see, either on clinical examination, and sometimes they'll do really well, with visual acuity, on some of the testing. They'll seem like they're okay, but they can't read. They get lost in the supermarkets. They'll put something down and they won't recognize when they pick it back up again. So you kind of get a flavor that something's not right visually, but you can't necessarily find anything. Sometimes if you pick up an Ishihara, they can't see the numbers because they can't make out the number among all the dots, but you often aren't the one doing that test.
Mm.
And it's actually only by observing people doing some of these tests that you really get to see what's going on. So I think the one that really came to my mind was a lady who'd been referred by her cataract surgeon. Referral, patient still complaining after perfect cataract surgery.
All cataract surgery was perfect. Cataract surgery, of course. How dare
Uh,
they? How dare they not see?
exactly. So it was clear that we needed something to help delineate when someone was struggling visually in a different way from our standard eye tests could detect.
Okay, and what type of pathologies are underlying the problems that these type of patients have?
So it's usually in the dementia sort of spectrum. It could be something simple like a vascular dementia, but often it's in the Alzheimer's spectrum. And sometimes more in that early posterior cortical atrophy version of Alzheimer's, where they're presenting with predominantly visual difficulties before the more recognizable cognitive symptoms. Um, yeah, so usually in that sort of space, I haven't used it in other, say, acquired brain injuries or concussion. I don't use it for that. This is much more in the dementia cognitive side of things.
And we shouldn't forget dementia with Lewy bodies, which is probably one of the most underdiagnosed forms of dementia
Yeah.
as well. So you're saying you don't use it in stroke patients, parietal strokes and things like that, or they just don't come your way, or
Probably because they're not coming my way. And because they've usually been diagnosed, like we know that there's a problem in the visual centers in the brain. So these are often more the subtle dementia patients that are presenting relatively well to the point where people would sort of take their cataracts out or check them for AMD, and they're not thinking down that pathway. Um, so I think some of the more severe patients will end up straight with neurology,
Mm.
which doesn't mean that the neurologist shouldn't use this, but I'm just sort of talking about my own personal experience. But it would also be equally valid for someone who has other forms of brain injury, like a stroke, for example. But then you'd have probably done a visual field and you'd have found the problem there. And yeah.
so that
Yeah.
little.
What about you? Can I ask if you what when are you using this?
So again, it's a dementia space, and most of the ones I've seen have been of the kind of Parkinsonian Lewy body type of end of it. I don't seem to get, for some reason, that many Alzheimer's and stuff. I think cataract surgeons are becoming much more aware of dementia, and obviously Alzheimer's being probably the largest group, they're going to see a lot of Alzheimer's. So that's what I was thinking. This book's going to be really useful for not just neuro-ophthalmologists, but general ophthalmologists and optometrists as well in their clinics, to, number one, explain why the patient's having symptoms they can't explain, but also to be the first person who possibly diagnoses a very important condition. Is that right?
I certainly found myself in that position using this, that I'm the first one who's actually finding something where the family can go, oh, why can't he or she see that? That of course that's what it is, and it's almost as much the family saying, oh right, now we get where the difficulty is coming from. In a way,
Mm.
and then that allows appropriate referral to a neurologist with an expertise in that area.
Yeah.
Yeah.
In the UK, it's normally memory clinics are the first place they get referred, which are often done by psychiatrists, old age psychiatrists, stuff like that. But obviously, different places will have different things. Okay, let's get on with the test. Why don't we just run through the pages and just tell us how to use it? Because it doesn't come with instructions, I don't think.
It's got the first little page. So I've spilt coffee on mine. The
Okay.
first page kind of tells you, so the first couple of tests are tests of early visual processing. Then it moves on to tests of object perception, spatial perception, face perception, and then tests of reading. There was a little one-page insert that explained that a little bit more. I've lost my,
Yeah.
I don't, maybe they've stopped
It,
me
in,
with it.
in the tradition of the Ishihara, which always had to have that little envelope place which lost the instruction book, all great tests have to have that missing instruction thing. So well done.
Yes.
Ring on that.
Yeah.
Okay, but it doesn't tell us how to do the test. So you can maybe talk us through maybe all of them or some of them now.
Yeah, no, absolutely. So this page is one of the first tests of early visual processing, and this is shape discrimination. And so what we do is we ask the patient to point to which two of these objects are squares, for example. So there are two squares and two oblongs.
Mhm.
They're fairly closely matched in terms of the area, but the patient needs to be able to point out, which ones are the squares.
Mhm. Yeah.
Um, in terms of the I guess the marking criteria there, it's not really kind of scored or marked in any definitive way. What I always recommend with these sorts of tests and with anything in ophthalmology is do it on a bunch of normal people. And so then you know what normal feels like. There's the speed that people are answering, that kind of thing. And so basically, if they get it wrong, then clearly they've failed in that test of shape discrimination. Or if they're really slow, then you just kind of get a feel that they're struggling. And this would, perhaps imply some bilateral occipital lobe pathology if they're failing at this very early stage.
And the other
There
thing, of
is
course, sorry, the other thing, of course, on the normals is you get to work out your patter. It's the wording of the questions is often important as well. So you don't be thinking, what should I be asking here? So yeah.
Yes, exactly. So I will say on this page there are two squares and two oblongs. Which two are the squares? Please point to them.
Okay.
So I try to keep it quite specific in the way that I ask the question. Um, but usually with these pages, I'm not having too much trouble with the understanding. So don't forget, we're screening for dementia, so sometimes you have to be a little careful in the way that you ask them. So that's a really good point.
Okay.
Mhm.
Next one.
The next one is the test that's for shape. It's called shape detection. This one. So I say we have four squares filled with static. Hidden in the static is a shape in two of these boxes. So can you point to the squares that have got a shape, and can you either draw the shape for me or tell me what it is? I find this one a little bit harder to explain to people, but I usually say there's a shape hidden in the static. Which boxes have got that?
And then maybe next step. Now, can you draw it all? Yeah.
Now, can you either draw it with your finger or tell me what the shape would be?
And they're crosses, are
Uh,
they? Those two?
they're crosses. Yeah.
Yeah.
Yeah. So
Yeah.
quite basic. And then the other one is the same, but the density of the static is a little bit more on this one than the previous one. So it's just a little bit harder.
Okay.
Um, so that's how I use those ones. This one is the next one, which is hue discrimination. And the reason that we do this is a bit like I mentioned, that the patients aren't very good at Ishihara because they've got simultanic nausea and they can't see the number for all of the dots. So I will usually cover them up and I'll say on this line there are three squares, which is the odd one out.
Okay. Hmm.
Again, because I'm not wanting them to then get confused with the number of squares that are on there. So I do sometimes just put my hand over it to make sure that they are really doing the test and not getting confused. So again, there are three squares. One is a slightly different color. Can you work it out?
Mm. Mm.
So that's the way I've been using that one.
Hmm.
And the next page is another one of the same.
Same. Yeah.
And again, with these, it's just, have they got it right? Have they taken too long to
Mhm.
get to the point where they're putting it right? And so when I'm writing in my notes, I will tend to write shape discrimination, tick or cross. I don't score it. It's just yes, no. Yeah.
Mm.
Did they guess it? Did they get it in a reasonable time? So that's how I'm doing it. And there is no scoring chart for this, as I said. So this one is shape size detection or size discrimination. So I'll say, and again, if they're struggling, I'll cover up and say there are two circles, which is the smallest.
And it's
There are
really
two
interesting.
squares.
That's a great one for the relatives, isn't it? Because it's almost like inconceivable. How could somebody not be able to tell which is bigger and smaller? It just seems so basic to those of us who have intact visual function. But when a relative sees that, they really know something's not right. Yeah.
Exactly. And I usually try to do it, where I've got the patient and the relative kind of both looking at the book together. And that's useful a little later on where there's potentially some cultural issues that may come into play with the faces and other things later on.
Yeah. Yeah. Okay, good. So that's
Yeah.
size. Okay.
So that they're really the four basic ones, which at the beginning we call sort of tests of early visual processing. And you need to be able to do these to be able to do the next ones. Like there's no point checking someone's facial recognition if they can't even tell what a basic shape is.
So if
Um,
they're struggling, if they've failed all of those, I mean, is there any point continuing? I mean, or are you just going to put them through agony? You better just bail out at that point, isn't it?
Pretty much.
Mm.
Yeah. I will sometimes go to this one, even if they have failed the others, because I really like this fragmented letters.
Mm.
Because it's, again, it's one that the rallies can see really easily that this is RMS.
Mhm.
And it's the patients will, this is often the one that where they will really fall first.
Okay.
Very unusual to have someone fail the others, but I find this is a really good one to really pick up that they're not
Mhm.
able to do this kind of visual processing. And what's really funny is the RMS is the Roads and Maritime Service. It's the RMS that gives you your driver's license in Australia. But it's actually quite funny that these are the letters that were chosen.
Interesting.
You can't read RMS, you can't have your license.
It shouldn't be driving. And that's a good point, actually. We'll talk about driving at the end, but and that's the same task as the Ishihara, seeing the number, because it's taking these individual elements and making them this. Yeah. Okay. Good.
Make the bigger picture from the. This, I believe, is the hardest page in the book.
I
So
tried this on my kids and they didn't get all of them, so it is a bit tricky. Yeah.
I think this one's very tricky. These are leftover photos from those formal tests that Dr. Elizabeth Warrington and Merla James Galton had done. So what I do is I say, look, these are photographs of four objects taken from an unusual angle. Can you work out what any of these four objects might be?
Mm.
And it's a sandal, a paintbrush, a clarinet, which is sort of an homage to Gordon Plant because he used to play the clarinet, or well, still does, and a bucket.
Mm.
So if they're men and they don't get the shoe, I'm fairly forgiving. If it's a woman and they don't get the paintbrush, I'm a bit more forgiving. If they say a musical instrument or, they don't have to say it's a clarinet,
Mhm.
but you just want that, like that they've got a feel. I think most, men and women should be able to get the bucket. So I'll accept bucket, musical instrument, and then one or the other, depending on the gender.
Got it.
So, yeah, I don't expect, as I do think this is hard even for people. And this is one that I will sometimes show the rallies and say, do you know what this is? And if they don't, then I'm a bit leaner.
Cross
What do you do? Is that how you play that one?
Yeah, I'm just forgiving, very forgiving on that. Yeah.
I'm a bit forgiving on
Especially the
this one.
clarinet. I think nobody's ever seen a clarinet from that angle. I think that's part of the issue. Yeah.
So we do have photos from the correct angle again, which is just sort of a reinforcement. This is now, can they even just recognize normal objects? I would expect people to definitely recognize the shoe, the paintbrush, and the bucket. And again, happy if they just say musical instrument. At
Okay.
that point. So that's kind of your object recognition, sort of gives you an idea about that kind of ventral temporal stream of your vision processing.
Mhm.
We get a bit tricky in this one. This one's a dot counting. I will usually with my finger cover up the numbers
Mm.
so that they don't think that's something to count. And I will say, without pointing at the page, how many dots are there above the line? And then how many dots are there below the line? If they can't do that, I'll then let them point.
Mm.
And then I'll ask them to point to the middle of the line. So
Okay.
it's like, so I'll ask them to point to the middle of the line. And sometimes if they've got a hemianopic defect or a bit of neglect, you'll get a feeling that they're pointing kind of more to one side.
Okay. Wow.
than
So
looking
that's
out, you know.
yeah. That's something I never realized before. I thought I was just a divide between the dots, but you actually use that as a test. That's useful to know. Okay.
Yeah.
And of course, this is the first one which really involves a kind of ocular motor kind of strategy. There has to be some planning of the eye movements and some memory of which path they've taken so far. So you can see that's another level of complexity. Yeah.
Yeah, we're getting sort of much more into the sort of the parietal stream, like the spatial perception. Yeah, exactly that kind of thing. And this one takes it another step further, which is the letter scanning. So I'll usually ask them to look for every time they look for the letter. I'll ask them to point to every time they see the letter T. Um, and, I want to see that they're kind of scanning across, that they're looking, that they're finding it on both sides of the page. So scanning across both sides, up and down. And yeah. Um, and it's not sort of one that I score, but I am more just looking for their overall performance and getting a feel for, is this something that they can do, or is this something that they are just not able to scan, not able to pick things out of a busy visual scene, for example.
Yeah. Okay. Good.
Yeah. This next one is called cube analysis. Oh, hang on. Oh, there we go. So
It's quite tricky, actually.
this one is quite tricky. And so the way I say with this one is I say, if I were to give you little cubes or building blocks, how many of those cubes would you need to build the
Okay.
object?
Yes, that's a good way of asking. It's not the way I was asking. That is a good way of asking. Yes.
So yeah, so that's how I do it, because I found otherwise it was so much harder. And again, sometimes I'll cover them up, and so you'll want them to say that they're at 5 for the top one, and then these get hard because now you've kind of got layering going on. So you want them to say 7 for that one, and then you've got 1, 2, 3, 4, 5, 6, 7, 8 on this one. So yeah, that they're able to get that 3D construction in their head and realize that there are layers behind.
It's really
Yeah.
holding a kind of mental representation of space long enough that you can then count what's in that mental representation. Yeah.
Yes. Yeah, but this one's tricky with how you word it. It took me a while to come to that one.
That's a pro tip. I like it.
There you go. This one is tricky.
Mhm.
Yeah. Now, this one, we decided that we would go for white men, because if we were to have like a white man, a black man, a white woman, a black woman, the black man's Obama, the black woman's Oprah. So we didn't want any kind of clues from that regard. So we deliberately made them all the same gender and ethnicity, so that wasn't a clue for who it was,
Mm-hmm.
which adds in its own layer of issues, because if you're not from a white country, you're not necessarily going to know all of these people if you don't have the cultural background, for Elvis Presley, for example. So this is one where I will say if the patient's got no idea, I will say to the family, do you know who this is? Do you think your mum, your dad should recognize any of these people, or are these some people who would be completely out of their
It has no
sphere?
relevance in your life. Yeah. So,
Yeah, I
so the
mean,
fact,
like David Beckham, no one knows who this is in Australia, except for a few women who think he's hot. But otherwise, people really don't recognize Beckham. For William,
with your future king of Australia, yes.
yeah, if they say one of the princes, that's fine, you know.
Good one.
But it is
With
very.
Clinton, yeah, Clinton's not many people can remember Clinton. It's certainly not looking like that. So, yeah, that one I think
This
is
one's tricky.
yeah, maybe it's yeah, needs an update perhaps. But then who would you put now?
Yeah, I mean, these people are of the age where they perhaps should recognize.
Mm.
Clinton probably would have been president when they were, young and middle-aged. But I agree. I think this is tricky because William has hair here.
Mm.
Beckham is still very young.
Mhm.
Yeah, the giveaway for Clinton is the stars at the background. So people will sometimes say, "Oh, he's one of the presidents."
Okay.
I
Something
don't know.
yeah, but we yeah, maybe have a bit more laxity on this one. Yeah.
I do. I mean, sometimes I might grab a magazine. Well, not anymore, not since COVID. I'd like grab a magazine and, who's kind of in the magazines I might expect people to know. What do you do with this one?
I miss out.
Yeah. Fair enough.
But then,
Um,
my patient group is, wouldn't expect half of them to know some of those. So, yeah.
yeah, yeah.
Okay.
This one is again facial recognition. So in this one, I'll say, who is the oldest?
Yeah. That's
Uh,
okay.
in
That's a really good one. Yeah.
Yeah, so I find this one quite good. The women is a little bit trickier to pick necessarily the oldest. So with this one, I might say who's the youngest because I think this one's clearly younger.
Yeah.
These ones might be a little trickier, meaning that this lady is the older one. Um, but yeah,
Who's the youngest?
uh,
Yeah. Good. Yeah. Good. I never thought of asking that there, but that is
yeah. So I'll
well
say
done. Yeah.
who's the youngest because I think that's easier, and then who's the oldest because he's clearly the oldest of those ones. And again, it's just sort of facial recognition. But as I said before, if they're failing earlier tests,
Yes.
then there's really no point continuing on to these ones. If they pass the others and they've got a very specific, prosopagnosia or some other kind of facial recognition problem, then you're going to find that a little bit with this. Yeah.
Mm. Okay.
Um, and then these last ones are tests of crowding. Again, I cover up the number at the top because I don't want them reading the number 18 to me. And so the way I do this is I just get them to read the sequences. And if they read the sequences on the following page much easier because they're wider space, then you know that there's potentially a problem with the crowding phenomena going on there. And this might be a reason why someone's not doing well on the visual acuity charts, but if you gave them single letters on the acuity, I mean, ophthalmologists are probably fairly familiar with the idea of crowding because of amblyopia. But this is also a phenomena when there are visual processing deficits as well. And so I'm really looking for the speed differential between the two,
Mhm.
um, rather than specifically timing or doing anything like that.
Yeah.
So
Okay.
a lot of these are just to give you an idea. This final one is the piece of text, which is officially meant to be the year 6 level reading. But some of the words are a little tricky. John Gifford was the kind of person who would go off sailing into his yacht, the Neva, around the island of Scorba. So they're not,
Mm.
it's perhaps a little trickier. Yeah. And again, it's just sort of reading fluency, how well they're tracking across.
Mm.
And it also gives you an idea of how they cope, again, with something that's quite crowded.
Mm. Mm. Mm.
Yeah.
Yeah.
So
Okay.
that's how I use it. And then with this sort of at the front here where it's got tests of face perception, reading, crowded, uncrowded, prose reading. As I said, I just write that in the notes, sort of ticking across, and you get a clear pattern as to sort of if they're failing early, if they're failing at sort of dorsal or ventral kind of pathway problems, just generally doing badly, and that gives me a clue that they need to go on for further cognitive testing, more detailed testing with the neuropsychologists is who we use here. I know you've got, there is sort of the core vest and the VOSP, which are the much more detailed tests by the same co-authors, but not me, if you wanted to take it further.
But to be
So
honest, I think once you've picked up the deficits there, I don't think you get that much from doing the same thing in greater detail. I think it's now moving on to other areas of brain function and really quickly getting to a diagnosis and lifestyle. So what I want to know is once you pick up these deficits in a patient, maybe you suspected it, maybe it's come as a surprise, you're like, aha, this is what's been going on. How do you then have the conversation with the patient and the relatives? Because I find this bit a bit tricky, especially when there's a denial going on.
yeah, it is
I've
very
got one patient in particular who would fail most of these things. I do my own kind of memory assessment as well. They fail almost all of those, and yet they don't want to acknowledge that there is a problem, neither they nor their husband. So how do you have the conversation?
That's a really tricky one. It is good having other members of the family in the room, and sometimes the children are better to have in the room
Mm.
than the husband, if possible. Um, And what I will usually start off with is sort of the stuff that's going well. You've had beautiful cataract surgery.
Perfect.
Macular degeneration. Perfect cataract surgery, not by me. It's two cataracts. You've got perfect cataract surgery. Your maculas are looking good. Your optic nerve is looking good. When you're doing basic tests of vision, we know they're working. So the reason that you're struggling is something else. And your brain is processing about, 50% of brain function is vision. We can argue how true that really is. But that's what I say to the patients, is that about 50% of your brain is being used in vision processing. And that's where you're running into trouble. Your eyes are sending all the right signals back, but your brain isn't able to sort of put it all together properly. So I don't use the word, I tend not to sort of jump straight into, oh, I think you've got Alzheimer's. What I'll say is your brain isn't putting together the visual information that your perfect eyes are sending back,
Mhm.
and that we need to kind of work out what we can do for that. And I will always test them for thyroid function. I'll check their B vitamins. I'll run through all of those sort of more organic, treatable causes of cognitive issues, look at their medication list, see if there's anything going on there, and give them other things that we're going to look for. Sometimes they might say, oh, is this dementia? And I'll say, well, that's on the list. We're going to work our way through it. We're going to involve your GP, your family care doctor, and if we're not finding anything in our early tests, then yes, we will involve a neurologist, and we might end up down that pathway. So I ease them into it with a
Mm.
lot of other things that I'm checking for, tell them all the things that are going well, and then do it that way, which I don't think is inaccurate. It just
That's good.
softening the ride in. I mean,
Mm.
I'd love to hear how you've been doing
Yeah.
this.
Yeah, I like the way you do it, of focusing on the positives. That's probably something which I haven't done enough. Um, but yes, I often find calling in a relative, especially the child, and I often do that on the phone. So I'll say to them, "Would it be okay? Is your son or daughter able to take a phone call right now?" And they'll normally say yes. And then I'll get them in on speakerphone, because they all normally know they're there at the eye department, and I'll say, "Look, we've just been finding these problems, and there may be some issues going on with the kind of brain side of things rather than the eyes." And they often then want to then say, "Oh yeah, I've been noticing this for ages. Dad won't accept it," and they do the talking. It's really useful to get them to come in, and they're so grateful. I'm sure you've experienced this, that the family are often so grateful that someone has corroborated what they have worked out has not been right, you know?
Yes.
So that's one thing. What do you do for memory? I use this 6-item cognitive impairment test, which is a GP screening tool, which I find it's validated. It's very, very useful and very quick. Do you do a memory test yourself, or do you leave that to another clinician, or?
I usually do the parts of the mini mental.
Okay, yeah, so you pick.
Yeah, so I
Yeah.
sort of not I tend not to do the full mini mental, but we'll sometimes add in some of those things as well.
Mm.
Oh, sometimes it's as much to convince the family again, but a little bit like what you were saying, that you need to give them further evidence that this is the brain, not the eyes.
Mm.
Um, yeah, so I don't, yeah, probably little parts of the mini mental rather than a formal memory test.
So, we'll obviously link to where people can get the blue book, but I'll also put a link to the 6-item test, because it's so simple and easy to use and it's validated. So I'll put that in as well. Okay, great. That's been really helpful, Claire. It's going to make me much better at using the book, and I hope it'll make many people more aware of its existence and how to use it. And I really hope it gets rolled out everywhere, because there is much more awareness now of dementia in the eye clinic. I think Chris had a big session on it recently, but we've been
Oh,
aware.
wow.
Well, neuro-ophthalmologists have been aware of it for many years, but I think the cataract people are now getting much more aware of it, which is great. And then there's the whole issue of OCT screening for dementia and so on.
Yes.
Are you into that yet in Sydney?
Um, I don't do it. Well, the way I've sort of been saying it to the patients is that I don't do it on an individual basis.
Mm,
It's good on a population level, but I can't do an OCT and tell you what you've got.
mm,
I mean, we've done OCT analysis on concussion patients and those with traumatic encephalopathy syndrome, the pre-morbid kind of CTE diagnosis, and we are seeing some changes, but I wouldn't use it on an N equals 1.
mm. I've
Yeah, do
actually
you?
no, but, obviously
No.
there's research out there, but as with all things, as soon as the research comes out, some people leap on it as a way to sell a new service. So I have seen that that is a trend that is starting, that people are, uh, will be very soon, offering you a dementia scan, I think will be very soon on the horizon by some people, which, I think ultimately we will get there, but yeah, probably not ready for it, at this stage, but, once we
No,
can.
I don't think it's ready for mainstream rollout. Yeah, so I've kind of been deflecting that question, on an individual basis.
Great.
Yeah.
Okay, Claire, thank you very much for your time. It's late night in Sydney, and we appreciate you giving up your time to educate us on the Blue Book, and we will include the links of where to get it at the end of this. Thank you very much.
And lovely talking to you. Thank you so much.